Hello, Assalamualaikum and good morning to all. My name is Dr. Yang Rafida Hassan. Can call me Dr. Yang. I'm a visiting lecturer in orthodontics. Today will be my very first lecture in ortho, which is orthopedic appliances. If you have any question regarding this topic, you all can email me at this email, rafida@pidc.edu.my. These are the three main orthopedic appliances that I will be covering in my lecture. The first one is headgear, the second one is reverse pull headgear and also known as face mask, and the third one is chin cup. By the end of this lecture, you should be able to outline the indication, contraindication, and the uses of headgear, reverse pull headgear and chin cup. So this lecture is divided into two parts. The first part is headgear and the second part will cover the reverse pull headgear and chin cup. So now let us focus on the part 1, which is headgear. In orthodontic practice, there are two types of forces. The first one is orthodontic forces and the second one is orthopedic forces. So what does orthodontic force do? It moves the teeth. So how does it move the teeth? By means of wires and other active appliances. So forces from this orthodontic force are very light and range from 10 to 120 grams. Whereas for orthopedic forces, it affects the deeper craniofacial structures, and these are heavy forces over 400 grams that can bring about a change in skeletal tissue. So, what is the basis for orthopedic appliances? So, orthopedic appliances will use heavy forces, and these heavy forces applied to teeth have the potential to radiate upwards and affect the nearby skeletal structures. For such skeletal changes to occur, forces employed should be over 400 grams. Thus, orthopedic appliances uses teeth as handles to transmit the forces to the adjacent skeletal structures. Nowadays, they have mini plates and mini screws that have similar effect of the orthopedic appliances. However, I will not explain this because this topic is beyond the scope of this lecture. Now let us focus on the factors affecting orthopedic appliances treatment. There are 4 factors that affect the orthopedic appliances. The first one is the amount of forces. The second one is the duration of forces. The third one is the direction of forces. And the last one, the fourth one, is the age of the patient. So now let's focus on the amount of forces. The force magnitude should be high, at least 400 to 600 grams per side, to make sure that only skeletal and no dental movement takes place. Such high forces produce hyalinization, which prevents or slows down tooth movement, and thus only an orthopedic movement is seen. Second factor is the duration of forces. Extraoral appliances should be worn about 12 to 14 hours per day so that we can have the desired effect. Increasing the duration beyond the optimal range increases the dental effect. An intermittent heavy force is less harmful to the teeth and periodontium than a continuous heavy force. This is also influenced by the fact that 12 to 14 hours usage helps achieve better compliance from the patient while achieving the desired skeletal changes. There is evidence that there is an increase in the release of growth hormone more during the evening and night, and it is associated with the sleep onset. Hence, nighttime wear is recommended. Direction of force. The direction of force application should be such as to maximize the skeletal effect. If no rotation of the maxilla is desired, then force is directed posteriorly and superiorly through the center of resistance of the maxilla. But the direction can be altered above or below the crest if rotation of the maxilla is also desired. Age of the patient depends on the malocclusion. For example, correction of the retrognatic maxilla using a class 3 malocclusion has to be corrected as early as possible, whereas correction of class 2 due to prognatic maxilla can be done as late as around puberty, unless there is indication that the child is experiencing psychological trauma or is at increased risk of dental trauma to the anterior teeth. Some appliances like the chin cup used to redirect growth of the mandible have to be used till the patient reaches a top level of growth. This is because mandibular prognatism can relapse, especially if there is a strong genetic component to it. So what is headgear? Headgear is a device by which extraoral force is almost always applied to maxillary dentition via a face bow and a strap on the head or neck for anchorage. Now let me introduce to you the components of headgear. So the first one is anchor unit, which is a strap covering the back of the head. And then the blue colored one is the force generating unit that connect the anchor unit to the face bow. Face bow is a metal that connect the outer bow and inner bow to the teeth. This is the intraoral view of the face bow that connect to the teeth. So what happened is intraorally there is an appliance that have a components which connect the face bow to the appliances. So you can see at the bottom picture is something that looks like Adam's clouds, and at the bridge there is something connected, and this is what we call a tubing. This tubing will connect to the face bow and to the headgear. So basically we have three main components of headgear. The first one is the face bow, which is the force delivering unit. The second one is the anchor unit, which is the head cap or the neck strap. And the third one is force generating unit, which is the springs and elastic that will connect between anchor unit and the face bow. So face bow is one of the most important components which help in delivering extraoral force to the posterior teeth. The face bow consists of the following. Outer bow or whisker bow. It is made up of round stainless steel wire in size of 1.2 to 1.5 mm in dimension and is contoured around the face. The outer bow may be shorter. Outer bow is shorter than inner bow. Medium outer bow is the same length as the inner bow. Long outer bow is longer than inner bow. Inner bow is made out of 1 mm round stainless steel wire and inserts into the round buccal tube on the maxillary first molar. The inner bow is adapted according to the shape of the arch. Stops in the form of U-loops are placed in the bow mesial to the buccal tubes to prevent it from sliding too far distally through the tubes. Junction is the point of attachment of the inner and outer bow, which may be soldered or welded. It is usually positioned at the middle of the two bows, and it may be shifted to one side in case of asymmetric face bow. So this picture shows the stop that will prevent the face bow from protruding inside the tube, and also the junction. Force generating unit. This connects the face bow to the anchor unit and delivers the force to the teeth and the underlying skeletal structure. Depending on the extent to which the force generating unit is pulled forward, the amount of force exerted varies. The force element may be springs or elastic. Anchor unit. This is the form of head cap or a neck strap which makes use of anchorage from the skull or back of the neck respectively. A combination of two may also be used. This picture shows the plastic strap, outer bow or face bow, and the safety release. And also it shows the wire tube, middle or upper tube, the outer bow, arch wire, headgear tube, and inner bow. Principle of force application in headgear therapy. So now I will explain one by one about center of resistance, the force, the point of origin of force, and point of attachment of force. Center of resistance is the point through which the resultant of the forces acting upon a body will produce a translatory movement. A force passing through the center of resistance of tooth will cause to translate or moving. Okay. So once we have a force passing through the center of the resistance, the tooth will move. If the force is directly at the center of resistance, we will have bodily movement, which is the whole of the tooth will move to the side. If we have a force which is from upward to below, it will cause the tooth to move downward and laterally. If we have the force passing through the center of resistance from downward to upward, the teeth will slightly intrude and move laterally. Alternatively, tipping will result once we have the forces above or below the center of resistance. If we have forces below the center of resistance, we will create a mesial root tipping. However, if we have forces above the center of resistance, the root will tip distally. The center of resistance of maxillary dentition is usually located between the roots of the two premolars, and the center of resistance of the maxillary bone is present at the posterior superior aspect of the zygomatico-maxillary suture. Therefore, to bring about translation line of action of force, then the force should pass through its center of resistance. A force vector will have to pass through the center of resistance of the dentition and through the center of resistance of the maxillary bone if no rotational effect are to be induced. If the force is below the center of resistance, we will create a clockwise rotation of the maxilla. However, if the force are above the center of resistance, we will create anti-clockwise rotation of the maxilla. Headgears can be divided as follows according to location of anchor unit. So it can be called cervical pull headgear, occipital pull headgear, high pull headgear, or combination pull headgear. Cervical headgear. The anchor unit in this headgear is the nape of the neck. These headgears are generally indicated in low mandibular angle case. It causes extrusion and distalization of the molars along with distal movement of the maxilla. When line of force passes below the center of resistance in both maxilla and dentition, it produces clockwise rotation of both maxilla and dentition. When line of force passes below the center of resistance of maxilla and above that of the dentition, this produces clockwise rotation of maxilla and anti-clockwise rotation of the dentition. For cervical pull headgear, if the line of force, which is shown by the red arrow, if the line of force passing to the center of resistance. The center of resistance is the green dot. So on the first photo above, we can see that the line of force passing through the center of resistance, it will cause the molar to translate. Okay. On the middle picture, when the line of force passing through below the center of resistance, it will cause the molar to have clockwise rotation. So for the bottom picture, when the line of force is above the center of resistance, it will cause anti-clockwise rotation of the molar. Occipital headgear or occipital pull headgear. These headgears derive anchorage from the back of the head. This type of headgear produces distal and superior directed force on the maxillary teeth and maxilla. When the line of force passes below the center of resistance of both the maxilla and dentition, this produces clockwise rotation of both maxilla and dentition. When the line of force passes below the center of resistance of maxilla and above that of the dentition, it produces clockwise rotation of maxilla and anti-clockwise rotation of dentition. This picture shows the occipital pull headgear. So above the top pictures shows that the line of force is through the center of resistance. So remember, the center of resistance is the green dot and the line of force is the red arrow. So above photo, the top photo shows that the line of force is passing through the center of resistance. It causes translation of the molar. So at the middle photo, it shows that the line of force is below the center of resistance of molar. So it will cause clockwise rotation of the molar. And then the bottom photo shows that the line of force is above the center of resistance of molar, and it will cause anti-clockwise rotation of the molar. Combination headgear, meaning that the anchorage is both occipital and cervical. Both are combined in one headgear. So when the force are equal, a distant and slight upward force is exerted on the maxillary dentition and maxilla. By varying the proportion of the total force derived from the head, cap, and neck strap, sorry for the typing mistake, the resultant force direction can be altered. Now the treatment effect. The treatment effect can be skeletal effect or dental effect. So for the skeletal effect, the maxillary sutures, namely the frontomaxillary, zygomaticotemporal, zygomaticomaxillary, and pterygopalatine sutures are the most important growth site for development of maxilla. Therefore, to alter the maxillary growth, the headgears act by compressing the sutures, thus restricting the normal downward and forward growth of the maxilla, while at the same time the mandible is allowed to grow normally. Whereas for the dental effect, headgear being a tooth-borne appliance produces certain dental effect along with a skeletal changes. Headgears usually cause distalization on the maxillary molar. Along with this, extrusion or intrusion of the molar may also be seen if the extraoral attachment is cervical or occipital respectively. The uses of headgear. First is for orthopedic effect, to restrain the forward and downward growth of maxilla and redirecting maxillary growth. The distal force in such case should be applied through the center of resistance of maxilla. 350 and 450 grams on each side for a minimum of 12 to 14 hours per day is required. You must remember this is important. Orthopedic effect from extraoral forces are best tapped in pre-adolescent years. Headgear may be used to distalize the maxillary molar to correct the class 2 molar relationship or to gain space for relief of crowding. Extraoral forces can effectively be used for this purpose when worn for a minimum of 14 hours per day. Anchorage augmentation. Headgears can be used to reinforce molar anchorage in high anchorage cases. The headgear should be worn for 10 hours per day and force volume should be around 300 grams per side. In maxilla, anchorage reinforcement is achieved by restricting the mesial movement of molar. Molar rotation. Correction is achieved by adjustment of the inner bow so that it produces a rotational force on the molar. As soon as the correction is achieved, the face bow should be readjusted to apply a direct distal force. Space maintenance. Most effective method of maintaining arch length is by using extraoral force. Mesial movement of molars is prevented and the face bow does not interfere with erupting teeth. Daily wear of 8 hours per day is required. Limitation of headgear therapy. Headgear cannot apply force directly to the maxillary sutures. The orthopedic force have to be applied through the dentition and therefore dental changes are inevitable seen along with skeletal effect. Patient compliance is mandatory for headgear therapy to be successful. If patient compliance is poor, then the headgear treatment is not success. An adequate amount of mandibular growth is required to catch up while maxilla is restrained. However, this may not always be seen clinically. Accidental injuries are a possibility. To minimize this, patient instruction should be given in full and safety mechanism in the headgear should be employed. Precautions. Hold the bow in the mouth while the traction force is engaged or disengaged. Very rarely, facial and eye injuries have occurred. If this happens, treat this as a medical emergency and visit your local medical hospital immediately. Immediately hold and restrain the bow if it becomes loose. Never remove the whole appliance in one piece. Disengage the force element first, then remove the face bow component. No vigorous activity when wearing the headgear. No football, no rugby. Okay. Never wear the headgear without the safety device being in place. Report any damage or breakage of the appliance as soon as possible. Stop wearing the headgear and contact the orthodontist if the bow comes out at night. Safety mechanism in headgears. Generally, headgear safety mechanism involve either the release mechanism or the safety bow. The release mechanism releases the neck or head strap from the face bow if excessive anterior force is applied, thereby preventing rebound injury to the patient. The safety inner bow is designed to prevent the face bow from accidentally disengaging from the buccal tube or to decrease the ability of the inner bow to cause injury. This picture shows the example of safety mechanism in headgear. The first one shows an elastic band attached to an additional hook on the inner bow and to the hook of the molar band. So when patient want to remove the face bow, the patient should remove the elastic first, then only remove the face bow. They should remove the headgear one by one. The second photo shows the locking face bow. When patient wants to insert the face bow, patient should lock the face bow inside the tube. And then if patient want to remove the face bow, the patient need to unlock the face bow first before removing the face bow. And then the third photo shows the safety relief force element. The way it function is when there is a excessive force and then the safety relief will disengage from the face bow. Okay, this is the last slide for part 1 of Orthopedic Appliances lectures. So now we will move into part 2. Okay, part 2 will be face mask and chin cup. So what is face mask? Face mask is also known as reverse pull headgear. Actually, both are the same. Growth modification for class 3 problem is the reverse of class 2. Treatment involves restriction of mandibular growth along with downward and forward maxillary growth. So mainly headgear is for the treatment of class 2, and face mask or reverse pull headgear is the treatment for class 3 skeletal problem. So headgear implies a distal force to the maxilla, and the resultant compression of the maxillary sutures can inhibit forward maxillary growth. Likewise, pulling the maxilla forward and separating the suture should stimulate the forward growth of the maxilla, hence promote the correction of the class 3 problems. Headgear which cause a forward pull of the maxilla are therefore called reverse pull headgear. Face mask, popularized by Delaire in 1970s, is one of the most common reverse pull headgear in use today. A face mask works on the principle of pulling the maxillary sutures forward with the help of anchorage from the chin or forehead, or usually both. A forward maxillary pull is applied with the help of heavy elastic that are attached to hook on the rigid framework. What are the indications for reverse pull headgear? Mild to moderate class 3 skeletal malocclusion due to maxillary retrusion, reverse pull headgear works best in young growing children around 8 years old. Ideal patient for face mask should have normal or retrusive but not protrusive maxillary teeth, as face masks cause forward movement of the maxillary teeth related to the maxilla. So if the upper front teeth is upright or slightly retrusive, that's the best case for face mask. Correction of post-surgical relapse after osteotomies and selective rearrangement of palatal shaft in cleft patient. This photo shows parts of a face mask. First is a forehead cap, then the metal framework and the chin cup or chin pad. These are the heavy elastic that connects the face mask to the teeth. The reverse pull headgear is made of a rigid extraoral framework connecting two pads that contact the soft tissue in the forehead and chin region. The pads are usually adjustable through the use of screw. Two sides of anchorage have the advantage that anchorage is spread over a large area, thus reducing the amount of force exerted. The elastic are attached to an adjustable anterior wire with hooks which are connected to the framework. The maxillary appliance should have hooks in the canine-primary molar region above the occlusal level for attachment of elastics. This places the force vector closer to the center of resistance of the maxilla and helps in pure forward translation. To reduce the amount of dental movement, it is better to spleen the maxillary dentition. To achieve this, an acrylic spleen is usually cemented onto the maxillary teeth. Biomechanical consideration. The maxilla can be advanced 2 to 4 mm forward over a period of 8 to 10 months. The appliance is preferably used for no more than 8 months, as there is a risk of gingival inflammation and desification of the teeth that are covered by the spleen. The amount of maxillary movement is influenced by a number of factors like amount of force. Successful maxillary protraction can be brought about by 300 to 500 grams of force per side in the primary or mixed dentition. Direction of force. A 15 to 20 degree downward pull to the occlusal plane is required to produce forward maxillary movement. In most cases of maxillary deficiency, maxilla is deficient in the vertical plane as well. Therefore, a slight downward direction of force is usually desirable. The line of force passes below the center of resistance of maxilla, producing a counterclockwise rotation of the maxilla and dentition. This results in a possible extrusion of maxillary posterior teeth, leading to a downward and backward rotation of the mandible. But If the clinical situation warrants a pure translatory movement of the maxilla, then the position of the anterior wire to which the elastic attached can be made to be more superior. For example, the extent of the maxillary rotation can be controlled according to the point of attachment of the elastic. Alternatively, a modified protection headgear, as shown below, can be used to get pure translation. Duration of force to vary between 3 to 16 months. On average, at least 8 to 12 months of wear is required to produce a desired effect. At least patient can use up to 12 to 14 hours per day. Optimal results are seen when face mask is used in a primary or early mid-dentition period. An optimal time to intervene an early class 3 malocclusion is at the time of eruption of the permanent maxillary central incisors. So it's around 7 to 8 years old. While a class 2 correction can be slightly delayed up to even the pubertal growth spurt, class 3 malocclusion have to be corrected as soon as it is noticed. This is because the maxillary is locked in by the mandible and the class 3 will worsen if not corrected. This is when the interceptive treatment is very important. Type of face mask or reverse pull headgear. First one, the most famous one is delay face mask. The left face mask is made out of a rigid square-shaped metal framework which connects a chin up to the forehead pad and has a wire for elastic attachment. The second type is Tubinger model face mask. It's a modified version of face mask in which the forehead cap and the chin cup are connected with the help of two middle metal rods. An adjustable crossbar is attached in front of the mouth to engage elastic. The third one is the petite type of face mask. Petite modified the left face mask by increasing the amount of force generated by the appliance, thus decreasing the overall treatment time. Appliance is made up of the single midline rod connecting to the forehead and chin. In this appliance, the forehead cap, chin cup and crossbar can be adjusted according to the patient needs. This video shows the summary of the mode of action of the reverse pull headgear. We can see that patient initially presented with the restrained growth of the maxilla, and we put the intraoral appliance, and then we put the face mask. Elastic is attached to the intraoral appliance so that we can have the force to move the maxilla forward. Then finally we will get the positive object back. Chin cup. It is an extraoral orthopedic device which is useful in the treatment of class 3 malocclusion that occurs due to a protrusive mandible but a relatively normal maxilla. Chin cup therapy attempts to retard or redirect the growth of the mandible in order to obtain a better anterior-posterior relation between the two jaws. Philosophy of the chin cup therapy. Mandible grows by a position of the bone at the condyle and along its free posterior border. So, once we put the chin cup at the chin, we will restrict the growth at the condyle. So, that is the philosophy of the chin cup therapy. Basic chin cup appliance design. The chin cup is an extraoral appliance that utilizes a head cap which is firmly fitted and seated at the posterior-superior aspect of the cranium as anchorage and has attachment for the placement and activation of the chin cup. It consists of the flooring, the force module, which is the elastic or metal spring that provide the desired tension level on the chin cup, and the chin cup, custom made or preformed, hard or soft. A chin cup can be custom made from plastic using a chin impression. A commercial metal or plastic cup can be used if it fits well enough. So this picture shows the components of chin cup. We have the anchorage for the head cap, the force module and the chin cup. the line of direction of force. There are two ways to use the chin cup. First, the line of force acting directly through the condyle, or the line of force acting below the condyle. Line of force acting directly through the condyle with the intent of impeding mandibular growth in the same way that extraoral force against the maxilla impedes its growth. So the principle is the same. If the line of force acting below the condyle, the chin is rotated downward and backward. Less force is required, and it will result in increase in facial height and a decrease in the prominence of the chin. Magnitude of force. Most authors recommend a force 300 to 600 gram per side. Initially, a lower force level, about 150 grams, may be advised for the patient to get used to the appliance. Once compliance of the patient is improved, then we can increase the force bit by bit. Duration of wear. A maximum of 12 to 14 hours per day of chin cup wear is recommended. The effect of chin cup. Redirection of mandibular growth in a downward and backward direction. Improvement in skeletal and soft tissue profile. Therefore, chin cup works well in patients with reduced or normal lower anterior face height, but is contradict in long face patients. Lingual tipping of lower incisors. Recent systematic reviews, however, have shown that chin cup does not stop mandibular growth. It only redirects the growth. If there is a strong genetic etiology behind the mandibular prognatism, the correction can relapse. So, if patient have a genetics of class 3 skeletal in the family, so the treatment of chin cup is not really successful. So, as a recap, so by the end of this lecture, can you able to outline the indication and contraindication and the uses of headgear, chin cup and reversible headgear? Okay. Alright, so these are my references. Basically, this lecture is based on Dr. Vivek Bajka PowerPoint slide, and I add a little bit of facts from two of my main references is Orthodontic at a Glance and Contemporary Orthodontics by William Profit. You can have a look on this book or by other recommended textbook. Okay, that's all for now. Thank you for your attention. If you have any doubts or questions regarding this topic, you can email me at rafidah@pidc.edu.my, or you can approach me every Friday. That's the time where I'll be available in PIDC. And I hope you enjoy this topic very much and have a nice day. Bye.